بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Um, um, my name is Dr. Islam, emergency medicine consultant, and our topic today is about acute poisoning, and especially the topic is related to the toxidromes. Initially, we have introduction, emergency management of acute poisoning. These are our objectives: definition, prevalence, types of poisoning and suspicion, early detection and early management, and the importance of toxidrome, definition of toxidrome, types of toxidrome, and the pathway of recognition of toxidrome. The definition of acute poisoning. Acute poisoning is adverse health effect related to the effect of chemical substance when entered to the body, whatever the route of entrance, either injection, skin contact, inhalation, or any other route. It can be this toxic chemical, can be a toxic substance, can be medication. It can be related to overdose or drug abuse. It can be occupational or environmental, biological, or envenomation. Intoxication are major public and preventable health issue, and it accounts for almost 1 to 3% of all emergency visits annually. The burden of the problem is, as we see, 260,000 patients were seen annually with acute poisoning in USA and 80,000 in England. Almost the overdose accounts for 1/4 of all suicidal cases, and the rate increased from 4.4 during 1999 to 14.7 during 2014. Those are cases of overdose from the total cases of suicide. We have 3 types of acute poisoning. The poisoning, as any medical legal issue, it can be divided into 3 types: intentional poisoning, semi-intentional poisoning, and accidental poisoning. Why we are classifying this the poisoning in this way? As we will see, the problem in acute poisoning is the suspicion and recognition, early detection of the poisoning. Mostly, the problem of poisoning is not in the clinical features or clinical presentation. The main problem is the recognition of the poisoning. Sometimes the recognition is very difficult, or it is far from the insight of the physician, so he is not suspecting or not expecting poisoning in that case with that presentation. So in our lecture today, we will stress on how to recognize, how to early detect, and how to identify it is poisoning and what type of poisoning we are dealing with. And the issue of treatment after that will be very easy and simple. Okay, so for this reason, we divided the poisoning into 3 categories as we see. The intentional poisoning means the patient or the person receive the toxic substance by his intention and voluntarily. What is the reason to do like that? The reason can be suicidal, can be homicidal, he wants to kill or poison somebody, or can be personal, individual, or group, as in war action and terroristic action. In this type of poisoning, the diagnosis is usually easy if the case is suicidal, as the patient may have previous trial or previous attempt. The patient may have some psychological or psychiatric problems. The patient may leave a death note or suicidal note, as I want to die because of like that, or he may keep the empty bottle or empty strip beside him when he took some medication, syrup, or tablet. It is easier in suicidal than homicidal. In the case of homicidal, if somebody wants to kill another by putting some, exposing him to some poison material, the homicidal should be investigated by the police or by the authority. So it is difficult a little bit to recognize intentional poisoning if the case is homicidal. The diagnosis of mass poisoning, like as we said, in war action and in terroristic action, it depends on what is called think HAZMAT. Think HAZMAT is a very easy rule. You can find one patient coming to you with suffocation and frothy secretions. One patient is accepted, may have some issue, some clinical issue or some medical issue. In the same hour, you receive one or two more patients with the same presentation. So you should think at that time there is mass issue. There is some condition affecting more than one person from different vicinity or different families. It is not in a family issue. So in this issue, we will apply the rule of think HAZMAT. It is called think once, think twice, then think HAZMAT. As if you receive one patient with a certain clinical presentation, you can avoid thinking about poisoning. If you receive the second with the same presentation, you will start to suspect. If you receive the third, خلاص, it is poisoning and it is mass poisoning. This is the issue. This is the rule of think HAZMAT. Think once, think twice, and then think HAZMAT. Okay. The second type is semi-intentional poisoning. You know you are dealing with a poisonous material, but you dealt with this substance in inappropriate way, so you started to have some poisoning, and it is very common in therapeutic purpose and in occupational poisoning, like those farmers using organophosphorus compounds as insecticide. In this case, diagnosis is easy and history is informative, and the patient or the person will not deny he has some poisoning. He will give the history very well, not like the intentional. The last one is the accidental poisoning, in which the exposure is not intended at all. It is not voluntary. The patient or the person may not know this material is poisonous, may be too old or too young to recognize the poison. The poison may be put in a regular bottle or regular place, so it is difficult to recognize. So it is taken by mistake. In this case, the history or the diagnosis is related to the suspicion and relevant history if you have enough history from the relatives or from the caregivers. Okay. When to suspect poisoning? We are facing many patients with critical situations in ER every day. Why we are not thinking about poisoning in each and every case? What is the problem with these cases? Why we cannot think these cases are poisoning? We have certain criteria to think about poisoning. First, these presentations are highly suspicious for poisoning if we have these circumstances. First, group of patients with the same complaint at the same time. 3 or 4 patients at the same time with suffocation. 3 or 4 patients at the same time with gastroenteritis. 3 or 4 patients with coma. Something like that, you should suspect poisoning. Patients with history of psychiatric illness and came to the ER with unstable case or unstable condition, this patient should be suspected as poisoning. Patients with history of suicidal attempt, patients found unconscious, one of the differential diagnosis and fatal diagnoses is the poisoning. Patients with history of substance misuse with injection marks or with history of substance misuse. Collapse in workplace that use hazardous material, like in factories, in agriculture, in chemical industry, something like that. It will be a very high suspicion to have some poisoning. And for sure, patients presented to you with a toxidrome. Now we will talk about toxidrome. Toxidrome, what is toxidrome? Toxidrome is a syndrome or group of signs and symptoms that lead to certain chemical or certain type of poisonous material, as these signs and symptoms are made by this chemical material. What is the benefit? It is, if it is a clinical fingerprint or it is a classic constellation of symptoms and signs to toxic effect of chemical in the body, okay, we can make a group of some signs and symptoms for anything. But what is the benefit? The toxidrome, the only and the main benefit of the toxidrome is to, as we said, easy recognition of the poisonous condition, early detection of the poisonous condition, and the rapid management of the poisonous condition. The rapid management, as if you have this set of signs and symptoms, you will know what is the suspected chemical this patient have or this patient ingest. Okay, so it helps in early detection of poisoning, rapid management, and better outcome. Okay, toxidrome or syndrome is important because it provides a tool for rapid detection of the suspected cause and can focus the differential diagnosis to consideration of only a few chemicals with similar toxic effects. Okay, we have well established 5 categories of toxidrome: the anticholinergic, the cholinergic, the sympathomimetic, the opioid, and the sedative hypnotic. Some references talk about the serotonin toxidrome. Some talk about the hallucinogen toxidrome. It is not that common and it is not well established, but we will talk about these 5 toxidromes in brief. And as we said before, our target today in this lecture is not to discuss how to manage each toxidrome, but how to identify each toxidrome. Okay. What is the physiology of poisoning or physiology of toxidromes? Initially, we have central nervous system and autonomic nervous system. The autonomic nervous system is responsible for every sign and symptoms found in poisoning, in acute poisoning. The autonomic nervous system has 2 parts, the sympathetic and the parasympathetic autonomic nervous system, and both are not it's not correct to say it is against each other. They are against each other, but it is some sort of discrepancy. This will cause tachycardia, this will cause bradycardia, this will cause hypertension, the other will cause hypotension, in to keep the equilibrium or the balance in the body during the day. Okay, so as we will discuss every sign and symptoms of every toxidrome, you will find the effect of the neurotransmitters and the effect of the autonomic nervous system is very obvious in each toxidrome. Okay? Okay. The first one is anticholinergic toxidrome. From the definition or from the name, anticholinergics means it is against the cholinergic effect of parasympathetic nervous system. So it tends to give some sympathomimetic effect if they have taken in large dose or in poisoning dose. Okay, so anticholinergic toxidrome, the physiology is inhibition of muscarinic and cholinergic neurotransmitters, gives the drug its effect. The drugs like antihistaminics, sleep aids, tricyclic antidepressants, cold preparation, atropine, and cyclopentolate as eye drops. And in the plants, the belladonna is the most famous, as it is the main source of the atropine in nature. The clinical features is very common, very famous also. There are 6 parts: red as beet, dry as bone, hot as a hare, blind as a bat, mad as a hatter, and full as a flask. 6 points. First one, red as beet. Beet is a plant, it's very red. So it means the patient is flushed, vasodilated. Dry as a bone, there is no sweat. Sweat glands are inhibited. The patient is hot, he is hyperthermic. The patient is blind with fully dilated pupils, and the vision is very hazy. Mad as a hatter, the patient is having delirium and sometimes hallucination and seizures. And full as a flask, there is inhibition of the autonomic mechanism for urination and defecation, so the patient will be constipating and retention of urine. This is the clinical features of the anticholinergic poisoning. This is the photo. It is very informative. Here it is blind as a bat. I cannot see for the dilated pupils. Mad as a hatter, confused. Dry as a bone, without sweat, and full as a flask, as there is urinary retention. Red as a beet, the patient is skin is flushed, and the patient is having tachycardia, absent bowel sounds, shaking, tremors, or something like that. Okay. The differential diagnosis, you should not forget to rule out the infection, as the patient is hyperthermic and he is agitated. So infection like sepsis or meningitis is common differential diagnosis. Salicylate overdose, it is similar like this presentation, and withdrawal of benzodiazepine or alcohol, as the case of delirium tremens will cause something like that. Okay. The treatment, as every poisoning, decontamination or stop the absorption of the poisonous agent, then supportive care, A, B, C, D, E, as we know. Symptomatic treatment as to treat the seizure, treat the arrhythmia, treat the abnormal vital signs, and then the physostigmine is the drug of choice to reverse this toxidrome. Second is the cholinergic toxidrome, is the reverse of that. The cholinergic toxidrome is very, very common and very widely seen in ER as the cases of organophosphorus poison, the insecticide used, and it can be absorbed from skin, from eye, from mouth, by inhalation, or by any type of contact. The physiology, the inhibition of acetylcholinesterase, this enzyme that that is responsible for the degradation of the acetylcholine, so the acetylcholine has no prolonged action. Once this acetylcholinesterase is lost, the acetylcholine will be acting unopposed without any antagonist. So the result will be exaggeration of the parasympathetic effect of the acetylcholine. Like the pesticides or the organophosphorus compounds in the insecticide or pesticide, the carbamate, and a medication called donepezil. The clinical features, it's called sludge and killer bees. Sludge and killer bees, 3 bees and sludge. So this is the muscarinic effect, and we have 4 nicotinic effects: salivation, lacrimation, urination, defecation, GI cramps and emesis, then bronchorrhea, bronchospasm, and bradycardia. This is the muscarinic. And we have pinpointed pupil, muscle weakness and fasciculation, paralysis, and CNS depression, coma, and seizure. This is the nicotinic effect. So, as you see, the patient is having fluids from everywhere: diarrhea, vomiting, lacrimation, salivation, bronchorrhea. The patient is sinking in his fluids. This is the photo for that. The patient is on the in the bathroom with diarrhea, urination, frothy secretion in the mouth, pinpointed pupil, sweating, crying or lacrimation, runny nose, and vomiting, and also he has some bradycardia. For this condition, there is no differential diagnosis as it is unique in presentation. You cannot miss, you should not miss this presentation. The treatment, as we said before, supportive treatment, ABCD, decontamination, stop the absorption, and then give symptomatic treatment, and then give the selective medication like atropine and paralidoxime. The third one is a sympathomimetic toxidrome. It is similar to the anticholinergic, but with some differences. The physiology is a sympathetic nervous system stimulation, overstimulation with high levels of catecholamine is needed to have this type of poisoning. The high dose or high level of catecholamine can be related to high dose of catecholamine, or the degradation of the catecholamine is inhibited, or the reuptake of the catecholamine is very inhibited, like in some medication. The medication like amphetamines, bath salt, cocaine, ecstasy, ketamine, and synthetic cannabinoid. The most important here in this toxidrome is the amphetamine, as the famous captagon in Saudi Arabia is amphetamine in nature. So the following slide will show you the clinical picture of the amphetamine poisoning or the captagon poisoning. The clinical features, everything is high, everything is stimulated. Hyperthermia, tachycardia, hypertension, agitation, psychosis, seizure, dilated pupil, and diaphoresis and hyperthermia. Everything is high. The patient may be confused, the patient may be psychotic, the patient may be hallucinating, the patient may be agitated. All are accepted in that case. This is the photo, or this is the diagram for the sympathomimetic or sympathetic toxidrome. Everything is high, and the patient or the person in the photo is there. They tie him with some ropes to keep him calm or to restrict his motion. The patient is firing, as you see in the bottom. He is very hot and very elated and very agitated and very risky. And the patient also is having some delirium or some psychosis, hypertensive, tremors, sweaty, making violent reactions, and he is what's called restless. This patient may go through this phase, then he may go down after consumption of his power to be offended or comatose after that. The differential diagnosis is very wide, as the patient, the agitated patient is having a lot of differential diagnosis, like the meningitis, sepsis, encephalitis, neuroleptic malignant syndrome, serotonin syndrome, malignant hyperthermia, heat stroke, anticholinergic toxicity, pheochromocytoma, delirium tremens, thyroid storm, or rhabdomyolysis. How to treat? Supportive treatment. As we said, stop the absorption, decontaminate the patient, support the ABCDE, give symptomatic treatment, and then there is no selective antidote or selective medication to reverse the sympathomimetic toxidrome, only supportive treatment. The fourth one is the opioid toxidrome. It is not common in Saudi Arabia. Opiates are a drug of abuse in many world countries, but it's not the commonest one in Saudi Arabia. So you may not see this type of poisoning in Saudi Arabia. It is related to stimulation of the opiate receptors, kappa, sigma, and mu. We have two types of opiate, natural opiate and synthetic opiate. The natural opiate like codeine, heroin, hydrocodone, morphine, and oxycodone. and the synthetic and the most important and most famous is the dextromethorphan in the cough syrup, fentanyl in sedation and anesthesia, methadone used in addiction therapy, and the famous meperidine, which is the bethadine, which is used in as analgesic. The clinical features, everything is down. The opiate uh, is inhibiting material. So the patient will be down in everything: bradypneic, bradycardic, hypotensive, depressed. The CNS is depressed. There is no reflexes. The patient is sleepy or comatose. There is pinpointed pupils, seizures, and some mix. Sometimes the opiate is mixed with some other medications. QT prolongation in case of methadone, bowel obstruction, and non-cardiogenic pulmonary edema in case of heroin. This is the case. The patient is comatose, okay, with pinpointed pupil and decreased respiratory rate or respiratory depression, hypotension, hypothermia, and there is some injection marks, and the patient is mostly a drug abuser. The differential diagnosis: hypoglycemia, post-ictal, coma for differential diagnosis, TVA, clonidine overdose, and acetaminophen overdose. How to treat: supportive treatment, and the selective drug is the Narcan or naloxone. It will reverse the effect of opiate by competitive inhibition on the receptor. Last one is sedative hypnotic toxidrome, like the use of some sedative medication or some hypnotic medication like benzodiazepine. It is depressing the CNS and increasing the GABA neurotransmission. The drugs are like barbiturate, benzodiazepine, chloral hydrate, ethanol, methanol, all these types of sedative and hypnotics. Clinical features: everything is down, hypothermia, bradypnea, bradycardia, hypotension, and CNS depression, lethargy, and coma. Differential diagnosis: don't forget the co-ingestion like the opiate and acetaminophen, and alcohol. If the patient is suspected to have alcohol, it may be methanol, not ethanol. The treatment is only supportive treatment. This diagram is a summary to the main manifestation and comparison between each type of toxidrome. Anticholinergic is high, temperature like sympathomimetic. The respiratory rate is down in opiate and sedative hypnotic. The patient is hot in anticholinergic and sympathomimetic, and cold in opiate and sedative hypnotic. The pupil is dilated in anticholinergic and sympathomimetic, and pinpointed in cholinergic and opiate, and so on. We have the final part of this lecture is how to diagnose or how to easily recognize the toxidrome. We have pathway or approach to check every patient suspected to have poisoning. First step is to check the pupil size. Pupil size may be pinpointed or may be dilated or normal. If pinpointed is one category, if dilated or normal is another category. If the patient have pinpointed pupil, we'll check after that the bowel sound. If the bowel sound is hyperactive, it means the patient has cholinergic poisoning or cholinergic toxidrome. If the bowel sound is hypoactive in pinpointed pupil, the patient may have opiate or opioid toxidrome. Okay, this is for pinpointed pupil. For the dilated or normal pupil, you will check the temperature first. If the temperature is high, so after that, check the bowel sound. If hyperactive, it is sympathomimetic. If hypoactive, it is anticholinergic. Okay, but if the temperature is low or normal, if the temperature is normal or low, check the bowel sound again. If hyperactive, it is hallucinogen, or if it is hypoactive, it is sedative or hypnotic toxidrome. This is the diagram of how to differentiate different toxidrome by three determinants: the pupil size, the bowel sound, and the temperature. we are done with the lecture today. Any question?